Hello friends, today we are going to discuss about the treatment of carbapenem resistant enterococci. So it is almost always difficult to choose antimicrobial regimens for carbapenem resistant gram negative infection. So understanding the mechanism of resistance either by carbapenemase production, that is KPC, IMP, WIM, NDM, OXA48, OXA23 like, or by any other mechanism, the carbapenem resistance is there, like efflux pump or purine loss, has an important clinical implications. So carbapenemase, that is beta-lactamase, is classified into two broad groups, that is serine beta-lactamase and metallo-beta-lactamase. This serine beta-lactamase group is again divided into class A, class C, class D. Class A includes KPC, IMI, and SNE, and CTXM and other. Class C include MC, CT, ACT, CMY, DHA, FOX. And class D includes OXA48, OXA181, OXA23, OXA40, OXA58, OXA1, OXA2, OXA9, and OXA10. And metallo-beta-lactamase include class B, that is NDM, VIM, and IM. Now, this carbapenemase resistant gram negative is again divided into carbapenem resistant enterococci and the carbapenem resistant non-fermenting pathogen. This carbapenem resistant enterococcus is again divided into uh, carbapenem carbapenemase producing enterococcus and the non-carbapenemase producing enterococcus. This carbapenemase producing enterococcus include, as I mentioned earlier, KPC, OXA48, NDM, and non-carbapenemase producing enterococcus produces the resistance by other mechanism like chlorine channel and the efflux pump. This carbapenemase resistant non-fermenting pathogen, it includes two classes. So it is further divided into two classes, that is carbapenemase producing organism and non-carbapenemase producing organism. Carbapenemase producing organism include KPC, OXA23, OXA40, OXA58, MBL, NDM, VIM, and IMP. Non-carbapenemase producing organism, the mechanism of action is purine channel in the influx pump. Carbapenem resistant enterobacterials, that is Klebsiella pneumoniae and E. coli. The treatment option when carbapenemase testing result is not available for complicated infection or hemodynamically unstable agent, we can use polymyxin. So polymyxin is not recommended for UTI plus another agent to which organism has demonstrated susceptible minimum inhibitory concentrations like tigecycline, aminoglycoside, IV phosphomycin, or a high dose of carbapenem if minimum inhibitory concentration is less than 60. So if even if results are not available and we are seeing the patient who is hemodynamically highly unstable and he is in like complicated infection, then we can add the combination of polymyxin with these agents like tigecycline, aminoglycoside, and IV phosphomide, and we can use the high dose of carbapenems. Ceftazidime avibactam alone, if in vitro susceptibility has demonstrated, or in combination with astronam, if synergy test is demonstrating zone of inhibition. So tigecycline is mainly approved for intra-abdominal infection and soft tissue infection. We should not use the tigecycline for bloodstream infection or pneumonia as a standalone agent. So polymyxin. So colistin is preferred over polymyxin for UTI as a single agent. For uncomplicated UTI like for uncomplicated infections like UTI and any other infection for which source of reduction has been done and the patient is hemodynamically stable. So aminoglycoside for uncomplicated infection like UTI or any other infection for which source of reduction has been done. So the treatment option when carbapenemase testing is available. Like if we know it that strain is NDM producing, then the first choice will always be the prolonged infusion of ceftazidime, avibactam, and aztreonam over 3 hours. And the other options are polymyxin plus agent to which organism has demonstrated susceptible minimum inhibitory concentration, like tigecycline, aminoglycoside, phosphomycin, and high dose carbapenem. Then tigecycline is approved for intra-abdominal infection, skin, soft tissue infection. They are not recommended tigecycline for bloodstream infection and pneumonia. Then we can use aminoglycoside for uncomplicated infection like UTI and any other infection for which source reduction has been done. Then, if we know the organism is NDM plus OXA48, then then also we can use the prolonged infusion of ceftazidime, avibactam, and aztreonam over 3 hours. And the other options are polymyxin. Again, the polymyxin is not recommended for the UTI plus other agent for which organism has demonstrated susceptible minimum inhibitory concentration like tigecycline, aminoglycoside, and IV phosphomycin. Tigecycline is approved for intra-abdominal infection, skin, soft tissue infection, and we are not using it for bloodstream infection, and aminoglycoside for uncomplicated infection like UTI. Then again, if it is OXA48, then we can use ceftazidime, avibactam, not aztreonam. And the other options in this is polymyxin, as I mentioned earlier, along with other agents like tigecycline, aminoglycoside, IV phosphomycin, or high dose of carbapenem if minimum inhibitory concentration is less than 16. Tigecycline again for intra-abdominal infection, soft tissue infection, and not for bloodstream infection. Aminoglycoside for uncomplicated UTI. Then if the organism showed KPC, then again we should use only ceftazidime, avibactam, and the other options are polymyxin plus other agent for which demonstrated susceptible minimum inhibitory concentration like tigecycline, aminoglycoside, IV phosphomycin, tigecycline for intra-abdominal soft tissue infection, and aminoglycoside for uncomplicated UTI. Now, the carbapenem-resistant non-enterobacterials, Acinetobacter baumannii and Pseudomonas aeruginosa. So, carbapenem-resistant Acinetobacter treatment options are high-dose sulbactam, that is 6 to 9 gram per day on its own, or ampicillin sulbactam or cefoperazone sulbactam. Polymyxin use colistin instead of polymyxin for UTI. Then we can also use minocycline, tigecycline. Tigecycline is not recommended for UTI. And the other agents like trimethoprim, sulfamethoxazole, and aminoglycoside. So the combination A therapy with at least 2 active agents, including high dose sulbactam, even if non-susceptible when possible, it's suggested for treatment of moderate to severe carbapenem-resistant Acinetobacter baumannii infection. A single active agent may be considered for the treatment of the patient with mild carbapenem-resistant Acinetobacter baumannii infection. And the mild infection, although may be difficult to define, but may include urinary tract infection, skin, soft tissue infection without hemodynamic instability. The agent of choice is sulbactam due to sulbactam's activity against carbapenem-resistant Acinetobacter demonstrate in vitro. It is useful to note that even if non-susceptibility to sulbactam is demonstrated, high dose of sulbactam may still be an effective option. Nebulized antibiotic for the treatment of respiratory carbapenem-resistant Acinetobacter is not recommended due to unequal distribution of the drug in infected lung and the potential for adverse reaction like bronchoconstriction. So the carbapenem-resistant Pseudomonas aeruginosa treatment options are use beta-lactam, that is ceftazidime, cefepime, beta-lactam-beta-lactamase inhibitor combination like piperacillin, tazobactam, cefoperazone sulbactam. If they are sensitive, then we can also use aminoglycosides and polymyxin for infection in which no other treatment option is available. Now, the treatment choice as per clinical syndrome. If it is uncomplicated cystitis, then go for trimethoprim, sulfamethoxazole, nitrofurantoil, and oral fosomycin. If there is a pyelonephritis or complicated UTI infection, then choose as per discussion above, but do not use tigecycline and polymyxin. Infection outside urinary tract, choose as per discussion above, but tetracycline is acceptable in intra-abdominal infection. Avoid using aminoglycoside for lung and the intra-abdominal infection. Then duration of therapy, if it is ventilator associated pneumonia, then 7 to 10 days. Complicated UTI 10 days. Then catheter associated UTI 5 to 7 days. Intra-abdominal infection 4 to 7 days. Central line associated bloodstream infection 10 days. Now, the dosage of common antibiotic used in the treatment for MDR, ceftazidime, avibactam, and aztreonam. Ceftazidime, avibactam, 2.5 gram IV every 8th hourly, infused over 3 hours, plus aztreonam, 2 gram every 8th hourly, infused over 3 hours. Colistin, 9 million unit as a loading dose, then 4.5 million unit every 12 hourly. Polymyxin, 15 lakh IU as a loading dose, then 7.5 lakh every 12 hourly. High dose of meropenem, that is a 2 gram IV every 8th hourly, infused over 3 hours, and high dose of imipenem 1 gram IV every 8th hour, infused over 2 hours. Tigecycline 200 mg IV 1 dose, then 100 mg every 12 hours. Minocycline 200 mg IV every 12 hourly. Sulbactam 2 gram IV 6 to 8 hour. IV phosphomycin 4 to 6 gram IV every 6 hour. Then high dose of ampicillin sulbactam, that is 2 gram of ampicillin, 1 gram of sulbactam, 9 gram IV every 8 hourly over 4 hours. Then safoporazone sulbactam, that is 4 gram IV every 6 to 8 hours. Thank you.